how we can apply it for the improvement of plants and animals. We are grateful to have you here. So next up in the row, we are honored to have us a distinguished keynote speaker whose main research involves deciphering molecular pathogenesis on neuropsychotic disorders, employing genetics, pharmacogenetics, and immunogenetics, epigenetics. He is currently working as a scientist at Human Molecular Genetics Laboratory in Neurobiology Division of Rajiv Gandhi Center of Biotechnology. With this, I would like to welcome Moinak Banerjee, sir, who is going to share his views on dissecting the double-edged sword of therapeutics, a connecting link between common and rare diseases.
Yeah, very good morning. So, thank you, Bruce, for initiating a very bright beginning, and thanks, Gyaneshwar and Prashant, for taking the initiative of genomics to a next level of activities. And both are extremely dynamic, very energetic, and I wish them that these people actually really keep on driving the genomic force to a much greater level there. So with this, I will actually try to start up with, I do really research in a real research way. And why I say that research, which I have actually demonstrated last time, that I work on precise diagnosis. Is there a precise diagnosis? Is there a precise medication? Can I do disease forecasting? So these are the three areas that we try to work on. And last time I talked about, these are the evidences that were known about the epigenetic signatures for pathogenesis and schizophrenia there. And I said that I don't trust any of these epigenetic signatures that has been reported historically for the last 30 years there. For a simple reason is because most of this observation has been done on the patient samples which were on medications and all that. So I said that those particular epigenetic marks that you say of pathogenesis might be actually induced because of the drugs there. And then we went on to prove through a series of publications and editorials saying that yes, through in vitro studies as well as through the patient biology, that yes, those were drug-induced signatures, but have very little to do with the pathogenesis marks there. But today I will not talk on schizophrenia. Today I will talk on something else. How many of you actually have these symptoms right now? Many of you may not have right now, but if you are actually facing an exam, then you might possibly having these symptoms quite often there. And what do you do when you have these symptoms? You simply take a paracetamol, right? And to control your symptoms. So it's mostly for the women staff here. You can actually see that paracetamol is really not very safe there. And it's not a very small study. This has been done with 1,85,617 mother-child pairs, where they say that prenatal exposure to paracetamol in pregnancy can increase the risk of overall cerebral palsy and unilateral spastic cerebral palsy there. So that is a link between the common disease and the rare disease there. So the rare disease that we are trying to investigate, are they really rare in nature or not? So tomorrow, I'm sure that some of the people who are sitting here possibly will be sitting on the other side of the investigation, and they will say that Moinak, you have been saying this particular thing, whereas you yourself are working on the rare disease there. How do you justify those? Yes, this is the scenario where none of us really understand what really causes the rare diseases there. not only this one example there. So if paracetamol doesn't work, you possibly try out many other NSAIDs, right? And what happens with the NSAIDs? Of course, if you see the paracetamol, it has been reported with both animal studies as well as human studies that it can increase, it has a association with ADHDs, autism, hyperactivities, and many other conditions there. So paracetamol is definitely not very safe during pregnancy there. Similarly, when you talk about, then you will possibly try to go for other painkillers. Diclofenac is one. Diclofenac can also result into an increased risk of cardiovascular risk there. And not only diclofenac, you can go on, and again, this is again not a very small study. In India, we cannot really pursue any study of this magnitude there. For a simple reason is we don't have very precise healthcare data records available to us to do such a study there. Whereas the UK can really do it very phenomenally well there. Similarly, when you try to see that not only diclofenac but all other NSAIDs, most of these NSAIDs actually has an increased risk of cardiovascular risk there. So it's almost buy one get one free there. So it's a big bazaar offer for many of you there. So and then what happens is with some of the symptoms you will say, oh, this could be because of acidity and all that, right? And as a result, you try to take ranitidine there. And you can see Rantac can also result in large number of cancers there. So now it's not buy one get one free, buy one multiple free there. So and then what happens is, yes, you should be very careful in taking medications. And of course, then the conditions which possibly are that I am going to talk about is associated with hypertension also. So therefore, many of the antihypertensives, it's almost a very random method of giving medications, and as a result, many of the medications actually don't really work so effectively there. So many of the antihypertensives don't work so effectively there. And then we have 250 such individuals who have developed these malformations because of anti-epileptic drugs there. We are working on this particular aspect also. And so many of these conditions are still classified as rare disease conditions, cleft lip, septal defects and all. And we have all these conditions which have been generated because of the mother was taking anti-epileptic drugs. And we have 250 such patients from a single hospital in Kerala. And these are all labeled as rare conditions and all that. I work with 2 heart repositories in the country. Both the heart repositories are not even aware of that these septal defects can be induced because of the medications itself. So therefore, a lot of heart disease that you work on, I'm sure that you are actually not working in the right direction there. And on the top of it, 91.2% of the FDA approved drugs have not been tested for teratogenic potential there. And then comes the drug discovery. If you literally want to investigate, you read these 4 books, you will really find out the truth of the drug discovery process and the protocols and all that. And of course, the topics that they are covering, which is not covered, what I keep on talking about why drug discovery is actually a myth there. Because my hypothesis is purely based on the data, and those data is not been and this particular those data is not part of these particular books and all that. So therefore, one has to really worry about the medication aspects there. Then comes is why. So then, what are those symptoms and all that? So with these symptoms, I actually proposed a project way back in 2004, and the funding agency said, "Oh, this is not a priority area." But you see that they say that this is not a very common condition there. This is a scenario which is basically caused that particular symptoms that I showed you in the initial slide was because of a cerebral stroke there. And this can happen while giving a speech. This happened in Trivandrum. A person who was, while giving a talk, he collapsed and he died instantly there. So it can be so severe in nature there. And you can see that this particular press note, you can see in 72 hours, there were 29 people who died because of cerebral stroke there. That too in one particular place there. So it is so pathetic, and not only that, you can see that this lady actually underwent a lot of CT scans, MRI scans, but still the clinicians could not identify what was the real scenario, and they gave her, they discharged her from the hospital saying that you are actually have a migraine, so gave her anti-migraine medications, which is again paracetamol. But 2 days later, she turns out to be in a completely vegetative state, and of course, she did not survive. And the reason is she had developed this aneurysms which ruptured, and due to which, because the extent of bleeding, one person can die instantly there. So it is very, very severe there. But the funding agencies has to realize that how severe it is unless it really affects them there. So then comes the challenge is, do we really have enough doctors to really handle it there? In India, this is the US, it spends close around 20 to 30 minutes per patient to evaluate patient symptoms. In India, we spend only 2 to 3 minutes per patient. And of course, we can't expect to spend more than 2 to 3 minutes, because then there will be a long queue of patients standing in the OPDs. And therefore, as a result, I stopped going to the hospital because I am scared of the long queue I have to stand in for undergoing any evaluation around that. So therefore, in 2 minutes, you can't really do a very precise diagnosis there. And at the same time, we have only very few doctors, and medical errors is considered the third largest cause of death in US alone. So in spite of spending 20 to 30 minutes per patient, the medical errors cost is the third largest cause. You can imagine what was the scenario in India there. So very, very negative notes there. And of course, and on the top of it, the medications that you tend to see, these are the medications that is available in the market, which has not been even approved by the Indian Drug Controlling Authority, but it's available in the market there. And these are all benzodiazepams, then various anti-diabetic drugs, antihypertensive drugs, and all that. And this was not the scenario in India alone. Even in US, when they proposed the similar project in US in 2007, you can see that the people who die because of cerebral stroke, one form of cerebral stroke, that is aneurysm, is 24,297. We all know about AIDS, we all know about breast cancer, but the number of deaths that happens due to this aneurysm is almost equivalent there. But the number of projects that has been given in 2007 in US alone was only 2 projects there, which was costing only $20,000. And now, and of course in 2023, scenarios have not changed. It is still more or less the same there, 17 projects there. And there are plenty of people who died. You must have even seen Abdul Kalam getting to the stairs, who actually collapses there, again because of cerebral stroke there. So what we did is we tried to investigate how severe this condition is. So what we did is we tried to not only talk about the cerebral stroke, which is actually not only with intracranial aneurysms, but also about ischemic stroke and intracerebral hemorrhages all put together. And we try to find out what is the prevalence, incidence, and mortality of these particular conditions across the globe. And most often what happens is, whenever you talk about the research, people actually will talk about one condition at a time because it's easy to work with. So what happens is, if I'm trying to develop a model for stroke there, not understanding that the stroke doesn't come alone there. There are plenty of comorbid conditions which actually associate with stroke, which drives the stroke to be much more pathologic in nature. So therefore, this comorbid conditions also has to be really very seriously taken off. And whenever you're trying to do Jiva studies or gene expression studies, microRNA studies, or methylation studies, and then you have to really worry about, are you really investigating the marks of the stroke, or are you really investigating the marks of some of these diseases which comes along with it. And if you don't trust me, this set of articles, this set of statement will further prove that large number of studies, non-comorbid conditions, large number of animal studies and human studies have been done globally with using non-comorbid conditions. Means you're talking only about stroke or diabetes alone there. You're not talking about other comorbid conditions that associate with the disease conditions there. So what we did is therefore we thought that let us try to investigate, is it that the stroke and its comorbid conditions across 204 countries, do they actually inherit in the same way? And we looked into all the 204 countries, and this is about the mortalities we have done for the incidents and all from 2009 to 2019. And if you want to see that, yes, overall these are the various 190 countries for which the data has been presented here. You can see that there is a color coding pattern shows that there is a prevalence differences or mortality differences across the countries there. Which when we try to group these into continents, you can see that the ranking pattern in the continents also tend to change there. This is the global pattern 1, 2, 3, 4, 10 to 11, and this is the and you can see that it really varies across various continents when I group those particular 198 countries into various continents and all that. So ideally, yes, it varies across continents. Then when we try to look into the mortality, the correlation of mortality rates of stroke and its subtypes. Yes, there's a lot of data. We can again see that there is a difference in the pattern of correlations between of mortality with stroke and its other subtypes and all that. No, don't worry about so much of data for all these countries. Then what we did is we try to further investigate that. I try to group these conditions of comorbid conditions as metabolic conditions for stroke, and this is the stroke, various types of strokes, and this is the blood pressure. This is a major driver for the stroke. Then. And then we try to investigate, do these metabolic conditions, systolic blood pressure, and others, how do they really associate with the stroke? And you can see that, yes, this is the global pattern, and this is the global average for metabolic conditions. The green is the metabolic conditions. You can see that the metabolic drivers are more prominent in the US, Mediterranean, European countries, whereas the hypertension is the major driver for in India and East Asia and Central and South Asia. There. So when I group all these comorbid conditions across all these countries and all these continents, you can see that the drivers for US and India is quite distinctly different there. If this is true, we always blame that India is the diabetic capital there. Now you can say that yes, India may not be the real diabetic capital there. There might be some other countries. So with this, we are very keen to investigate. This is how the public health research also goes on, and we were trying to investigate. Does it have? And they have been mostly talked about in terms of socioeconomic parameters. Then. But we wanted to investigate, are there any genetic correlates and all that. And then what we did is we tried to investigate, we tried to fish out all the Jiva studies that have been published till late for all these conditions, and we looked into all the risk variants that have been reported for overall stroke 389, ischemic heart disease 1178, systolic blood pressure 439, so on and so forth. There are so many variants for that has been reported through the various Jiva studies, and we try to see whether using all this Jiva's data, how do this ethnicity differences are reflected in my when I literally investigate from the global point of view there. And you can see that yes, this is the European population, the East Asian population, the American, this is South Asian, and this is the African there. You can really cluster them when I talk about all this comorbid conditions, strokes and all, I can really see that using the Jiva's data, I can really cluster the entire world. I can really stratify the entire world into 5 different regions there. I can go further deeper into it also, and to see how do these variants really look alike, and you can see that yes, this is the African cluster, which is quite distinctly different from the rest of the countries for most of the disease conditions, and this is the East Asian component. You can see that they are more or less distinctly different from the rest of the from each other. Then we further wanted to investigate how many of these variants are unique, and we can say that yes, there are plenty of unique variants. There are only few number of variants which are actually common across the disease conditions and all that. And as a result, Jiva's data that has been applied in one particular continent may not be really applicable across the other continent. You really have to generate a data for your own countries very specifically, and also you have to generate a data for the comorbid conditions also to understand your disease population very precisely there. So then we wanted to see how do this really through very complicated Venn diagrams. I of course don't get into these. These are actually stroke, and how many of them are actually common across all the continents, and how many of them are unique for various continents. These are various continents, and these are the unique variants for each of these continents. There are some which are common across stroke and other countries and all that. So I don't worry about it. So which clearly again shows that there are plenty of unique variants within each continent. There are plenty of common variants for all the continents, and but more important is that how do this set of various variants really imply with respect to the various biological pathways, and we again did a lot of gene ontological pathways, try to find out the unique and shared variants. Don't look into so much of exhaustive nature of data for shared and unique variants. And of course, these are the blue ones is actually systolic blood pressure for various uh, and the various genes that are indicated here, and these are the various pathways there. So similarly, we have done for last, it continues for almost 3 pages. I'll summarize a lot of data, and if you want to go deeper into it, you can actually go into our eLife paper, which has been published regarding this, which will, of course, there are a lot of data, but we are not really talking about the entire data in one go. And as a result, and these are some of the unique variants, unique genes and their variants that are associated in African population, which mostly associated with the cadherin signaling, hippo signaling, and all, which are unique to this particular pathways to African populations. And East Asians and South Asians and all, there are some of the unique pathways that have been shown here, and unique genes. Then, so summing up into just one or two features of those particular unique pathways was that African and Asian population, we tend to see that inflammation and cardiovascular risk variants were much more enriched, whereas in European and American, it was mostly the metabolic transport of small molecules were mostly enriched in the data there. And the common pathways were mostly associated with cholesterol metabolism, complement and coagulation cascades, and CGMP and PKG signaling pathways and all. This is just a small segment of the particular entire data. And then we were very keen to investigate, do these, when you try to see this particular genetic variants, are they really also segregated across the various comorbid conditions? And when we try to look into our data again, we see that in aneurysms, which is again a form of subarachnoid hemorrhagic stroke, history hypertension is very strongly associated, cigarette smoking is very strongly associated, diabetes acts as a negative risk factor for Indian populations there. But this is not true across the globe there, because diabetes is a risk factor for cerebral stroke in the East European, Eastern Finland there. Whereas it is not a risk factor for Indian population. The reason is, in Indian populations, these falls into two different LD blocks, whereas in Eastern Sweden, this is one particular block which actually is a risk factor for stroke, and this is another type 2 diabetes, which is again a block which is risk factor for type 2 diabetes. They all actually fall into a single block in the Eastern Finland, whereas this falls into two different blocks in the Indian populations. Not Indian population, but in our populations, in the South Indian populations. So, which clearly indicate that yes, LD block patterns has to be investigated to understand, to dissect out the co-segregation of the comorbid conditions and all that. So I will not get into the entire data of it. I will just talk about one particular gene, which is called PCSK69. The reason is this particular gene has also been now there is a drug available for this particular gene for targeting stroke, and if you literally try to use this particular drug globally in the similar pattern, it may not be very useful. For a simple reason is because this is the PCSK6 risk gene, and when we try to find out the LD patterns for this risk variant across the various continents, you can see that this is the South Asian. Sorry. So this is the South Asian population, and you can see that this is actually forming a very strong LD block, but in the rest of the world population, it doesn't form a very strong LD block. So if it works out in these communities, I'll say that this particular drug may not be very effective in treating the patients of South Asian populations. So therefore, these LD-based mapping methods will possibly help you to dissect out how the various disease co-segregate or in the populations then to see whether a particular drug will work in the given population or not. So this is the paper that was published in eLife about the entire data. And as a result, what we say is that yes, phenotypic diversity is very, very important to understand it, to understand the comorbid conditions. It is also very important to understand the genetic diversity that exists. It is also very, very critical to dissect out the epigenetic diversity, to really talk about. So whenever we talk about any complex disease conditions, we have to first stratify these parameters so that we can really talk about the disease. We can really dissect out the genetics of the disease or epigenetic markers of the given disease. So that is what normally not done. So most often the geneticists will also say that what is the number that you're talking of. If I say that I am talking about 100,000 number for any common disease collected from all over the country, it makes no sense to identify genetic signatures, because 1,000 numbers will actually will be reflective of very small population segments from all over the country. But if I try to talk about 1,000 numbers from Kerala alone or 1,000 numbers from South India alone, I'll possibly get much better signatures for the disease signatures for a disease pathology than talking about 1,000 numbers from all over the country. So it's better to do a very small, a very classified study segment rather than really going for the numbers alone. And so therefore the issue is everything gets published. So you have to be extremely cautious that don't worry about the publication. Anything will get published. If you don't think that anything will get published, then go through this particular article. You will see that the practice of neurosurgery in Saturn there. People have not reached Mars even, but this particular paper got published where they have demonstrated that the neurosurgery practice in Saturn, how it goes on there. And it has been published in a journal there. So that clearly shows that anything will get published. Don't worry about it, but do the whatever little science that you are trying to do, do it in a very, very precise and a very structured manner there. It's almost like how many of you really like coffee? So many of you like coffee there. And how many are aware that coffee drinking is good or bad for health? So yeah, the people who love coffee, they will say no, coffee drinking is good for health. And people who hate coffee, they will say coffee drinking is bad for health. This is how the psychology of public health research goes on there. So I will say that don't really worry about the public health data at all there, because these are all full of myths there. For a simple reason is, these are the indications where coffee drinking is good for health, and these are bad for health, and these are the indications which shows that coffee drinking is very good for health there. As a counselor, I will say that you do whatever you want to do in your life there. Don't worry about it there. Right? But that is, as a researcher, I cannot say that, because coffee drinking actually depends on your metabolic parameters there. So it is your capability of metabolizing caffeine will determine how much amount of coffee that you can take it. So therefore, you should be really worried about your metabolic parameters of a caffeine, so that accordingly you can really take up coffee. If you are a poor metabolizer, you should not be taking more than 1 or 2 cups of coffee per day. And if you are rapid metabolizers, you can take 10 to 20 cups of coffee, nothing will happen to you. So take this message home, and possibly with this, I can go on for another segment, but I don't. I still have 3 minutes time. Okay. You're being mysterious there. So anyway, so this is how the story goes on. that everything gets published. So, but be careful. Don't trust all the public health researchers. Try to investigate, because the reason why I showed you a gory picture of the various medications. Don't worry about it. All medications are not very harmful. The medication actually, why it turns out to be harmful, because it has not been administered to you in a very scientific method. Because today, if you go to take paracetamol, you will be given 500 milligrams 3 times a day for 5 days. Very, very random approach there. Instead of that, your paracetamol should be given based on your metabolic parameters. And if you are poor metabolizer, you should not be taking. You should be taking 5 milligrams once or twice a day for possibly 7 days there. But if you are rapid metabolizers, you should be taking paracetamol 700 milligrams 3 times a day for 3 days there. But right now, if you try to work on from that particular parameters, many of the medications that I showed you a very gory picture of those medications that actually can really work very effectively, which we have demonstrated using anti-epileptic drugs for some of the pharmacoepigenetic signatures for which can be useful in preventing many of those malformations that I have shown you there. So with this, I'll stop here. So today we are trying to understand the art of medicine through genetics, epigenetics, pharmacogenetics. And what happens is William Osler said that made an observation that if it were not for the great variability among individuals, medicine might as well be a science and not an art. And today we are trying to investigate using this genetic and epigenetic parameters. So, and at my age, I know that we tend to be quite philosophical, and we try to do a lot of dissecting the research aspects. And so therefore, I have an evidence which I don't have the time right now, but where I can say that yes, many of these drivers, the genetic risk factors, are driven by your metabolic genes and your immunological genes. With our experience in autism, schizophrenia, stroke, dementia, and epilepsies, where we have shown that the common denominator for all the disease condition, environment is the major player, and the genetics of these environmental factors basically plays a very strong role, like immunogenetic factors and the one common metabolism genes, which actually plays an integral role with the environment to drive your genetic risk factors towards this. And for this one, we have done using a large-scale proteomic, genomic, and microRNA studies for epilepsies, for autism, and also for stroke, to dissect out how we can really address some of these issues. Then. So with this, I'll thank you all, and
thank you very much, Banerjee.
Thank you very much.
Now, the concept of time, one very beautiful question.
I think it is going to be a beautiful question.
Yes, sir, yes.
A unique type of research you are pursuing, but it is going to be a peril for all of us. Because if we talk of the paracetamol, we say there is a problem. We talk of any other pain reliever, we say there is a problem. And we specifically see in country like ours, where 90% of people, 50% of the problems are being taken only going to medical store without even consulting doctors. So how do you think that the complexity where you find that our body has a complex physiological system, and the way you suggest that you should be so cautious about taking the medicine, how you comment on this? Because comorbidity, several of the factors which we suffer, how do we address that?
Good. So I have heard the same question in the previous meeting of the INVIX. So the issue is that if I had been given the permission to bring my wife here, I would have possibly shown as a live example. She was actually on anti-diabetic, antihypertensives for the last 10 years. And for the last 4 years, she has stopped taking all medications. She is not taking any medications. But she's taking a set of medications which possibly many of you really ridicule it. But the particular medication is working very effectively, and all her parameters are completely normal. And if you ask any clinicians, they will say, "Oh, don't stop the antihypertensive, don't stop anti-diabetic and all." But she's a live example where she has stopped taking everything, and she is still doing fine there. So, and we have also demonstrated using in schizophrenia. It's very, very complex. We have demonstrated how yoga actually can really help in recovering symptoms of schizophrenia very effectively, even with using MRI scans of brain, that how the immune parameters are really coming back to normal, how the brain structure also is coming back to normal in schizophrenia patients. This is a very good study that we did with Nemans.
Just
Yeah.
one quick comment to provoke it. Just
Sir,
one quick comment
yeah.
to provoke it.
Please, sorry.
We
Yeah.
need the very great talk, but I thought that the complaint that we always make of the polygenic risk scores which we do on lots of European population is not predictive in nature.
Absolutely not.
But there is a confounding element there. Also, the arrays and other kind of devices we use to genotype, they do not capture enough the non-European population.
Absolutely. Absolutely. So that's what. So we have to generate our own arrays there, which is very clear that the arrays that we are actually developing, that we are using it, that is not applicable in Indian scenarios there. Absolutely, we have to develop our own arrays there. Breast. Absolutely.
It is absolutely right, But one thing, what he said, it has to go to public knowledge. Public knowledge, you have any YouTube? Please not on YouTube. As a scientist, you put your facts before coming.
I was asked by Prashant last time that we in the south and even in the country we actually hear about Dr. Hegade there, who is a cardiologist there. He actually gives similar anecdotal stories for anti. Yeah.
Government is well aware of this issue.
No.
Wait.
Government is not at all aware.
Wait. The recent policy of curative medicine, which is a preventive medicine, integrative medicine. That's what you are talking about. You are bringing alternative therapies like yoga, meditation into the doctor, into the umbrella of allopathic medicine. This is called integrative medicine approach.
I'll tell you.
Paradigm shift is there, it is happening, but what I request is that with your expertise, please come on to educate people.
I'll tell you just one example. One example. He says that the government is aware of it. The government mouth is basically the secretaries of the various funding agencies there. I was presenting the same thing, and so someone really commented that, "Oh, Moinak, you mean that all the drug discovery is actually all myth?" I said, "Yes, absolutely, it's a myth there." And then the person was sitting next to the secretary, and who was also a very distinguished scientist, who has been a director of a very prominent institution. He googled it out straight away, and he said, "Oh, what Moinak is saying is true." So it really hurt his ego. He left the room there right away.
Thank you.
Thank you so much, Moinak Banerjee, sir. Thank you for making us understand the art of medicine through genetics, epigenetics, and pharmacogenetics. Primary focus on stroke. Now, I would like to call on stage Dr.